Sir, now is the beginning of the JCM Shastri Symposium, and I request the moderators, Dr. J. Balasubramaniam, Consultant Nephrologist, Kidney Care Center and Kaveri Hospital, Tirunelveli, and Professor Dr. N. Gopalakrishnan, Director, Institute of Nephrology, Madras Medical College, Chennai, to come onto the stage, please. Dr. Balasubramaniam is a leading nephrologist from Tirunelveli. He is director of Kidney Care Center. It is beyond our imagination that he has performed 2000 ultrasound guide kidney biopsies, 800 adult peritoneal dialysis, 100 neonate and pediatric dialysis. Is definitely a brilliant work, well done. Since he has got his own well-equipped hospital, PGs do approach him for your job if necessary. Sir, I'm yet to get my share of Irtukadai Alva if you have brought for the delegates. And now to go about Dr. N. Gopalakrishnan, I'm sure all of you are aware that a good teacher teaches from the heart and not from the book. This statement befits our moderator, Dr. N. Gopalakrishnan, who has been instrumental in molding 55 nephrologists in his stewardship and 17 budding nephrologists at present. At present, he is a director and professor in his alma mater, namely Madras Medical College, where he completed his DM in nephrology. His core knowledge is linking clinical teaching and clinical research. Dr. N. Gopalakrishnan is instrumental in providing sophisticated renal care accessible to underprivileged sections. He was a recipient for the American Nephrologist of Indian Origin, ANIO Service Excellence Award for the year 2021. Now the first speaker on the stage, Dr. S. Kandasamy, can I have you on the stage, please? There is something magical about Dr. S. Kandasamy. His education was MMC Squire. His mentors were Sabapati Squire. Am I confusing all of you? His undergraduation was Madurai Medical College. His post-graduation in general medicine was from Madras Medical College. Of course, thereafter DM in Nephro from MMC in the year 2000. The mentor Sabapati Squires are Professor A. Ratna Sabapati and Professor M.A. Muthu Sabapati. His name and fame as a consultant in KMSET for the past 21 years is incredible. If only the cadavers were installed with the mouthpiece, they would have congratulated him when he transplanted the kidney from the cadaver to the live patient. Sir, here is a chance for you to share your experience of achieving excellence in cadaver transplantation. The next 20 minutes is yours, sir.
Good morning, everyone, and respected professors and teachers. Achieving an excellence in disease donor transplant is any nephrologist's dream. I'll be talking on some interventions which may be of some help to achieve this goal. There is a lot of improvement in the organ procurement and surgical techniques and better availability of immunosuppressive drugs and prophylaxis against infections all would lead to an excellent short-term outcome. The one-year graft and patient survival have exceeded 95%. The excellent short-term outcome is very difficult to improve upon. Long-term outcome historically is unchanged, but recent data on SRTR suggests that there is a 43% increase in the half-life of the deceased donor transplants over 20 years' time. The median half-life of the deceased donor kidneys in the current era is about 11.7 years as against historical 8.2 years in the past. The improvement observed in the long-term transplant is not only because of the improvement in the survival of the allograft, also because of the improvement of the patient survival. The progress in the survival is not uniformly observed, and it is largely noted among the patients who are disadvantaged after transplant, namely diabetic, hypertensive, and old recipients. So it is possible that the better management of cardiovascular diseases, malignancies, infections, and diabetes would have led to this improvement in the long-term outcome. Optimization of the organ donor is a first step to limit the organ injury and maximize the organ utilizations. The interventions used are largely based on pathophysiological theories, and so there is no insufficient high quality evidence against these interventions. The interventions include corrections of hypovolemia, corrections of DI with vasopressin, and improving the organ perfusions with starting dopamine and weaning of noradrenaline, and targeted hypothermia of 34 to 35 degrees centigrade for the donors, and lung protective ventilations. Of course, a large dose of high methyl prednisolone is largely practiced, but without outcome benefit demonstrated from any pooled data. So coming to dopamine, it's a heme oxygenase 1 inducers which limits the productions of free radical generations, so expected to decrease the TGF. In a randomized trial of 264 donors, the experimental arm received dopamine about 4 mics per kg per minute for a mean period of 344 minutes until the surgical cross clamp, and they observed that there was a significant reduction in the TGF in the experimental arm. And there was another randomized trial failed to show any benefit of starting dopamine. However, the trial outlined that an infusion time exceeding 7 hours would improve the early graft function. So the donor hypothermia of 34 to 35 degree is observed to decrease the incidence of TGF in a randomized trial in US, and hyporemi is a multicentric randomized trial which is ongoing, which comparing the induced hypothermia, targeted hypothermia with the normothermia, and all these centers involved in the studies were using machine perfusion as a standard of care, and the results of this intervention is expected very soon. Belcher has introduced the concept of hypothermic machine perfusion as early as 1968, but the machines were very large, bulky, very difficult to transport, so static perfusions with UWS solutions and HTK solutions became a standard of care. With the increased usage of extended donor and DCT donors, there is largely utilized to decrease the waiting time on dialysis and is associated with the increased incidence of TGF. So hypothermic machine perfusions, hypothermic oxygenated perfusions, and ex vivo normothermic perfusions are increasingly used to decrease the incidence of TGF, also to study the viability of the organs by biomarkers as well as on the perfusions data. And Nicholson from Leicester, UK, pioneered normothermic perfusions by modified cardiopulmonary bypass method. In normothermic machine perfusions, the oxygenated red cell perfusate is used for a few hours just before reimplantations to dissipate the succinate buildup and to improve on ATP generations, and this perfusate does not contain platelets, neutrophils or complements, which are the mediators of ischemic reperfusion injury. This is the pictorial representations of normothermic perfusions, but no biomarkers independently has shown to predict primary non-functions or decreased graft survival. So based on biomarkers, organs should not be discarded. This is another flowchart which shows that multiple interventions to improve on the outcome of disease donor transplant, starting from cooling the donors and normothermic perfusions just few hours before reimplantations. So now there is a data and meta-analysis for Colagon in 2013. He studied 7 RCTs and found that the relationship between the hypothermic machine perfusions and TGF, the relative risk of 0.81 was demonstrated, and subsequently meta-analysis by Ponticelli et al. Found that the relative risk as low as 0.77 equate to 10.35 hypothermic machine perfusion usage to reduce the incidence of 1 TGF. And also the outcome benefits are demonstrated by Zank and Euro transplant data that 1 year and 3 year graft survivals are better than static cold perfusion. So normothermic regional perfusions is now being used in some part of the world in DCD donors. This is connecting the patients to extracorporeal oxygenator for a few hours immediately after circulatory arrest, and it is continued up to retrieval of the organs. And a large cohort study from Taiwan has shown that among the DCD category 2, 3, 4, the 5 years outcomes are comparable to DBD donors, and similar outcomes have been demonstrated from Madrid. So this is a pictorial representation wherein the immediately after the circulatory arrest, extracorporeal oxygenator is connected with a Fogarty balloon occluding above and below and perfusing all the intra-abdominal vital organs. So DCD, the long-term outcomes is demonstrated to be equivalent to DBD donors, and 10-year survival of 74% is demonstrated among the first transplant recipients. In UK, DCD has rocketed from 3% in 2000 to currently 44%, and Eurotransplant outnumbered DBD by 2011. UK and Australia principally focus on controlled DCD, whereas France and Spain follow uncontrolled DCD. Netherlands follows both. In India, the biggest problem is legislations. There is no mentions on Doha Act 1994 and subsequent modifications how to use the organs after circulatory death. So delayed graft functions in organ disease donors, the inflammatory immunological signals are started long before organ removal, and with the development of TGF in the recipients, there is the damaged fragments are recognized as damp by the doll-like receptors, and which elaborates the nuclear factor kappa B and interferon 3 and starts the inflammatory milieu. So no doubt it may be a risk for developing rejections, and some studies have shown this association of increased rejections and decreased graft survival with development of DGF, but other studies have not shown such associations, and UK registry has shown that the importance of number of TGF days, and they found that if the TGF days exceeds 14 days, there is increased risk of death sensor graft failure. But SRTR does not provide any data specific to number of TGF days. But single center data from Mayo Clinic, which studied about 1,714 donors, observed a very high incidence of TGF of 59%, and because they have accepted very complex donors like donors with high KDPA, AKI, DCD, and nationally allocated kidneys. And their observation was that as long as the TGF is less than 28 days, there is no associations between, there is no risk of increased rejections or adverse graft outcome. The point to be noted in the study is that they have started tacrolimus on the day of transplant itself, and they targeted a level of 8 to 10 immaterial of the development of TGF. So what's the take on the CNI, whether it's early or late? There are 3 RCTs available in cyclosporin era, which have found that there is no increased incidence of TGF with the early initiation of cyclosporin. Similarly, there are 5 RCT to show that there is no increased incidence of rejections by delaying this cyclosporin initiations. But altogether, this RCT suggests that there should be no reason to delay the initiations of CNI. And a paper from Colombia reported by, which has shown that by delaying beyond 24 hours, there is high incidence of biopsy-proven acute rejection to the tune of 19.4 as compared to 6.4% with the early initiations. And they found that hazard risk of delayed initiation for biopsy-proven rejection is about 2.95, extremely high. So we know that carbon monoxide is a poison, and it is produced by a heme split by heme oxygenase normally in all cells. And normally we have a carboxyhemoglobin of 2 to 3%, and it is increased in smokers and infants. And there is now animal transplant data on kidney and heart about the usefulness of carbon monoxide in preventing ischemic reperfusion injury. And US FDA has set a safety threshold of 14% of carboxyhemoglobin for the trials in kidney DGF. and it is readily eliminated by the lungs. So the mechanism is that it prevents cell death by blockade of caspase and mitochondria mediated oxidative injury, and it downregulates the pro-inflammatory pathway and coagulative pathway. And phase 1 trial has shown that there is no adverse effect. There is ongoing phase 2 trials, and in animal studies both the carbon monoxide and carbon monoxide releasing molecules were found to be effective. What is the take on HLA match on transplant outcome? We know that in cyclosporine era, CTS and Eurotransplant data have shown the good association with the HLA matching and the graft outcome, and there is about 20% better survival in the graft outcome if DRB mismatched recipients as against 4 antigen mismatched recipients, and there is about 17% improvement in the graft outcome, 10 years outcome, if there is a zero mismatch for DRAB as against 6 antigenic mismatch, all this in cyclosporine era. And now that Leiden University, Netherlands observed that in cyclosporine era, the DR match decreased the incidence of biopsy-proven rejections. The additional effect of HLA A and B were observed only in patients with the DR compatible group. Even a single DR mismatch makes the A and B matching ineffective. These are the observations from Eurotransplant data. And UNOS observed that currently there is diminishing importance of matching with the current tacrolimus era, and the kidney allocation policy based predominantly on HLA matching should be modified. Other factors like donor retain its statistical significance, and new allocation system was introduced in the US in year 2014. And KDPI, that is Kidney Donor Profile Index, replies the ECD definitions. KDPI considers 10 factors as against ECD, which considers 4 factors. KDP assesses how long a deceased donor kidney would function compared to all the kidneys recovered in the previous years, and KDP of 20% means that it expected longer function than 80% of the kidneys retrieved from the previous years. So a KDP of a low percentage means that good quality and expected longevity. And the drawbacks is that if one factor out of 10 is not available, it cannot be computed, and this does not take into account of the recipient factors, and predictive value is poor as shown by the C statistics of 0.6. So the developed countries are moving from HLA based predominant allocations to longevity matching, and the idea is to the kidneys expected to function longer or allocated to the patients who are expected to live longer, and kidneys of donors age 35 and below are allocated predominantly to pediatric populations in UNOS, and Eurotransplant in the senior program, recipients above 65 years are provided kidneys aged above 65 years, and most of the countries gives national priority for highly sensitized to avoid their prolonged waiting. So in the newer allocation system in US, the lower KDP, that is a good quality kidneys, are given to recipients with a better EPTS, that is expected post-transplant survival score, which is based on age, diabetes, pre-transplant status, and time on dialysis and diabetes. So a KDP of less than 20 are given to patients with EPTS score of less than 20, and KDP of more than 20, EPTS is not considered. So by this change in the allocation policy, they found that there is 7.7% increase in the number of transplant, wherein the age difference between the donor and recipient is less than 20, and they found that there is 22.6% decrease in the number of transplant, wherein the age difference is more than 30 years. So what is followed in Tamil Nadu is it's divided in 3 zones. Allocation is not HLA based. The donor hospital can utilize a kidney, the shared kidney goes to the pole, and there is no preference for the sensitized recipients. If there is no takers for a kidney from a zone, it is given to the other zone, and pediatric donors are given to only pediatric recipients, and this can be beyond zonal region, and old people above 60 years are provided deceased donor aged 60 and above, and longevity matching is not yet implemented in TN model. Gobert described that poor outcome of the graft and increased DGF when there is global sclerosis more than 20%, And following that, there is a lot of discord in US. And now currently more than 50% of the retrieved kidney from US are subjected for pre-transplant biopsy, but there is no uniformity in the methodology, technique, and the indications. And UNS has come with the indications as kidneys with KDB of more than 80, donor with diabetes, hypertension, and AKA should be subjected for pre-implantation biopsy, and the report should be given to the receiving hospital. So UNS recommend on a wedge biopsy, which has the demerits of getting a subcapsular tissue, so may overestimate a glomerulosclerosis. So what is practiced in UK, punch biopsy is ideal, and it is done on a non-perfused flaccid kidney, and frozen section should be avoided as it can cause artifacts with the hyalurosis and interstitial fibrosis. So rapid processing with 4 hours with formalin fixation and paraffin embedding is what is recommended. And the caveat is that there is only 60% concordance with the pre-implantation biopsy with the reperfusion biopsy. And a lot of histological scores are available. Ramuji score is what is popularly practiced, which is based on the percentage of glomerulosclerosis, tubular interstitial fibrosis, and arterial wall thickening. And the score can be graded from 0 to 12%. And initially, the Ramuji score of 0.3 was allocated to single kidney, and 4 and 5 were given for dual kidney, and 6 and above were discarded. But Fernandez-Laurenti studied the long-term outcome of the kidneys retrieved based on pre-implantation biopsy in his World for World program, and found that when the score of 4 was allocated to single kidney transplant, he observed that there was no difference in the outcome compared to Ramuji score of 0.3, and there was no difference in the outcome between 4 and 5 and 6. So he suggested to use a score of 4 to use it for single kidney transplant, and not to discard score of 6 and to utilize for dual kidney transplant. Cambridge also followed the same protocol, and dual kidney transplant, so it is encouraged to expand the donor pool and preventing discard, and UNS recommends if any of these 2 following factors if present to consider for DKD. I take 2 minutes, sir. 1 minute. Yes. Donor age above 60 and high terminal creatinine or low GFR at presentations and high degree of glomerulus. This is my data, which is published last year in Indian Journal of Transplantation, retrospective data of 118 patients, all received basiliximab with triple immunosuppressive. The TAC was started on the day of transplant, like even before transplant, like what is practiced in Mayo Clinic. And except one patient, so all the patients had a cold ischemic time less than 12 hours, and 8 patients, only 6.8% TGF demonstrated in my study. And the study consists of 10.16 DSA positive. In that group, 91.6% graft survival was demonstrated. They received desensitization concurrent with the transplant. And 11.1% had rejections. At 19 months, the mean creatinine was 1.12, and 12 patients lost the allograft with the functioning graft. 1 year unadjusted thing was 93%, and 5 years was 81. When the death censored graft loss was censored, graft survival was 97.5% for the first year and 90.7% for the 5 years. This is a Kaplan-Meier in age less than 60 years. At 99 months, the graft survival was 84%. Conclusion, targeted hypothermia in donor and use of dopamine in donor is encouraged, though high quality evidence is lacking. Meta-analysis of HMP and ECD, DCD donors shows reduced incidence of TGF, better 1 year and 3 year graft survival. NMP, NRP in DCD can be done, but it increases the cost. Phase 2 trial on carbon monoxide is awaited, and there should be no delay in insertion of CNI, and pre-implantation biopsy may be practiced, and control DCD would increase the donor pool if our legislation permits. This is one of the ECD kidneys, 72 years, looks with multiple cysts, and used in a 62-old recipients. He has now 4th year post-transplant with a creatinine of 1.5. So not to discard ECD kidneys. Thanks. Wish you all a happy academic feast.
Thank you, Dr. Kandasamy. We'll move on to the next talk, and we'll have the discussions later.
Yes,
Sorry, we have been given the unenviable task of keeping. We are more of timekeepers than giving comments. Please go ahead to the next
Yes,
talk.
the next speaker, thank you,